on this episode of A Tale of Two Hygienists.
You have these, where's the patient's motivation? Is it me? I'm food motivated. If I was losing all my teeth and I want to eat steak, sign me up. Okay. It's somebody else more aesthetic motivated. Some people that their dentures slip, so they don't, that's their motivation, is they want the dentures to be fixed in place. Find where they are and where's their motivating factors to move forward. Now, what's more interesting is that referral and the study groups with the referrals, and you'll have a surgeon that would like to show larger cases that they're doing. And so we as hygienists sit through these surgical cases, and it's not really what applies to us. We want to know, what do we do at the end of the case? But we as hygienists do need to understand what's involved in the surgical planning of these cases so that we can better communicate with our patients, because we have the quality time with our patients.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 442. My name is Andrew.
My name is Annie. I'm so excited to be here.
Yay, Annie, you're doing an intro with me. Hooray.
Yay.
We have a great show for you, everyone, today. We welcomed in Lynn Pencek to the show. We had a really good introductory conversation, and that's kind of, I think, the intent for a lot of these shows. When we haven't had a topic for a long time, let's bring it back to the kind of the basics, and that's hopefully we're establishing a baseline of sorts for you all, the listeners, and then she's going to come back hopefully many more times, and we're going to build off of that. But Annie, I know you couldn't make this one, but I really missed you and like your scientific brain on this episode, because you and Lynn are going to get along famously.
Love that. And I'm so bummed to miss it. And yes, anyone, if we start talking research, I just get going on it. So I'm definitely future episodes next time for sure. So I know next week we also have a really exciting topic coming up. We had the chance to chat with Kate Murphy on insurance fraud investigations, which is a really interesting topic, and she shared quite a bit with us.
It's fascinating, all of the things that we couldn't even say on air. Yeah. I really wish that it was like, this is like behind the scenes, like unmasking this stuff, because fraud is just, there's not probably a better word. Fascinating is the best word I can come up with right this minute. It's so freaking fascinating. Yes. But that's going to be a great episode. Everyone make sure you tune in next week for that. But we're going to do something now for the show that we haven't done in a really long time, because I haven't had a co-host to talk about it with.
Great.
But we're going to just something came up this week. It's actually, so we're recording actually on Monday the 1st. And today is a holiday. Do you know what holiday it is?
I do not know what holiday it is today.
Okay. It's Bobby Bonilla Day. Do you know who Bobby Bonilla is?
No.
Okay, this is gonna be phenomenal.
I'm wondering how many people know who this is, because I don't.
No one.
Okay,
no one probably does.
I'm like,
and that's probably less of an issue. Like, who cares who he is? But it's what he did and what's happening. I think that is the most fantastic thing. Okay. So here's the thing: every July 1st, baseball player Bobby Bonilla gets paid $1.19 million from the New York Mets. He hasn't played in forever, right? Like, he is so far retired. I don't even know how old he is. He's probably in his 50s. So in a nutshell, there was this time, I think it was around the year 2000 or whatever, that the Mets owed him just shy of $6 million, which by today's standards, not really that big of a deal for a payout for a player, right?
Right.
But rather than taking that payout back then, he structured this deal so he would get this $1.19 million each year for a total of $30 million.
Oh my
right?
gosh.
But here's the catch. It didn't start in 2000. They weren't going to start their payments until 2011.
Okay.
And then they run through 2035. So right now is 2024. He has 11 more years of this $1.19 million coming in every July 1st. So here's my question to you. Who got the better end of that deal?
Him or the Mets?
Yeah, him or the Mets.
I feel, well, at least in my opinion, I mean, I feel like he did. Like, I mean, the fact that, like, he's not even playing anymore and he still gets his $1 million every year for doing nothing. Like,
and it was $6 million and now it's $30 million.
Right.
Like, it, you 5x'd your like number that you were going to get paid originally.
Right.
Yeah.
Like I think that's pretty amazing.
And the thing about that too is like you hear all the time about how ball players go bankrupt and like, they just can't manage their money, all that stuff. And it's like, well, now he has this like security. For sure, he's going to get paid. Another weird little aspect that this is totally behind the scenes. You know what we're going to do? I'm going to do a tip episode on this same topic for Friday, because I think there's so many more avenues we can't talk about on this little intro. But it's the whole like greedy aspect. Like, we want to get paid now. We want our money now, but we're not really thinking about our future. Yep. The thing is, like, he's now living in Florida, which is tax-free, versus New York State, which has an income tax. Also, ball players, as they're moving around to different states, no matter where, like, certain states where they have to pay like the tax. Yep. Yeah, exactly. Yep. And so now it's like, it's tax-free, all of the other stuff. But here's the thing, though. If the Mets were smart, they had 11 years that they could have put that same $6 million into some sort of a bank account.
Oh, sure.
And then they could have paid him on interest alone. Like, so I'm like, I don't know. And maybe like, what if he dies before 2035? Like, is he still like this? Does his estate get paid, or is there whatever? Right. There's so many more things I want to talk about, but like, isn't that a fascinating, happy holiday to you?
Honestly.
I know Independence Day is coming up in a few days, but like Bobby Bonilla Day, Independence Day.
You know, that's pretty sweet. Like,
where are the fireworks?
I mean, that's some pretty good planning, I think, on his part, and just living retirement and living in Florida, like you said. I mean, there's some good things there. Yeah.
So, I mean, I think there's more to talk about, because also, what if he would have taken that $6 million and invested it back then? What would he have had now compared to the $30 million? Would that have compounded interest by 35 years? So, we're going to talk about all of that. I think maybe on a tip episode, if I can get my my sources together and put that in there, but. Man, listeners, look, I'm so happy that we were able to have these like weird conversations. Some of them will be about dentistry. Annie's going to bring up some things that she sees maybe in some forums, or maybe some, please don't do the research. No, we talk about research too, like interesting research.
Yeah, it won't be boring.
But that's going to be fun. One last thing though, before we throw it to the interview, listeners, we did have some audio issues on our connection with Lynn. We tried to clean it up the best that we can. We have some really good tools that cleans it up, but sometimes on Lynn's track, her audio trails off, like her voice trails off, and there was no sound to like elevate that sound. So I'm apologizing about that, but we did our very best. In the future episodes, I'm sure that it won't be an issue. So make sure that you come back and listen to Lynn again. But with that, thanks for listening and enjoy this episode with Lynn.
A tale of two hygienists.
Listeners, welcome into the interview portion. I'm joined today by Lynn Pencek. Lynn, thank you for joining me today.
Oh, Andrew, thank you so much for having me. I'm so excited to be part of this.
Look, listeners, we have a really great game planned for you. It's going to be all about implants, something that we haven't really covered, as you all know if you're a regular listener, that we haven't covered that very well in honestly the last 2 years. So we brought on an expert here. Lynn is really good at this. And we're hoping this is going to be maybe even like a part one of a multiple part series. But Lynn, if you don't mind, just sharing with our listeners a little bit about your background, where you're coming from, your experience in the industry.
Sounds great. So I went to hygiene school right out of high school. There was no looking back. I always wanted to be a hygienist. And my mom was very upfront that after I finished my 2-year degree to stay in school. I'm like, well, Mom, I'm making great money as a hygienist. And she's like, stay in school. So I went to Thomas Jefferson's 4-year baccalaureate program. I was a student at Joanne Granlian's and Anna Eschenauer's, and I was encouraged to go for a master's. And I went to University of Maryland for their master's in dental hygiene. So I'm an odd one. I have a master's in dental hygiene. You know, if I could do it all over again, I probably would go for like a marketing or a business degree now. But that's another story. So I thought at that point in my life, I'd become a clinical instructor. I was part-time faculty at Jefferson until the program closed, and I was the faculty member obsessed with posture. And somehow I fell into a job with Orthoptics. So I worked in industry most of my career. Orthoptic and Nobel Biocare are the same company. They're both under that Invista umbrella. So you'll find that a lot of these companies will host meetings together. And Nobel would host a speaker on implants, and I would be invited to be part of the event and show loops to the customers. And it was really interesting. There were things I understood, and there were things I agreed with. And it was my life was changing. The loop position required a lot of driving. and a position opened in the Nobel territory close to my home. And it just made perfect sense to make this type of transition, smaller territory, better quality of life. And I thought I knew a lot about implants because I sat through a lot of continuing education on the topic. So I signed up for the position. And when I went through my training of how to become an implant rep, boy, did I realize I was wrong. I realized I knew nothing about implants. There were things that seemed familiar, but the whole process of learning digital workflow, surgical case planning in the software programs, STL files, it was just so overwhelming because it was really more surgical and computer programs that I was learning about, not so much hygiene maintenance of implants. So I was my expectations of what the job was were a little off. My expectations of being a high performer comes with 15 years of experience. You don't do that right away. It's not like selling loops where you have a great year, first one out of there. And I also became this rep just before COVID. And my thought was during the pandemic, I was going to get let go because I was a new employee and Nobel invested in their education of their employees. And it was like a residency. So early morning, 5 a.m., you're on these calls with Germany and you're taking classes from the European team. And in the afternoon, 4 p.m., you're on calls with California, with the West Coast team. And so for months, there were all these classes that I was taking. And it's amazing where you get overwhelmed. And then one day it starts to make sense. So it's been quite the journey.
Well, it's interesting that the focus, with the background of dental hygiene, the focus for you was more about, computer, digital, like learning all this other stuff that wasn't about kind of our core principles of like existence. How did you find kind of that integration or maybe the where you could help maybe bridge that gap for others?
It's every office is different. And I like to use the fishbowl analogy in private practice that when I go to work, I'm in my own enclosed environment and I'm the only hygienist in my office. And I'm working with one doctor who's got their philosophy of working with implants. And every hygienist works in a different environment. We're all in different fishbowls. So, you can't just say one blanket statement because depending on the year of education, the amount of continuing education that the employer or the practice has, what study groups do they belong to? There's all different philosophies. So everybody's got a different environment. And, it's important to take lots of classes to see different viewpoints and then understand how to apply it to where you are. And we all know that, our employer went to a class, learned about a new product and wants us to start using it, but it might philosophically be against what we think. Or we take a class and we want to implement this in the practice and the doctor's like, too expensive, not now. So it's the same. I find one of the things when I stopped working as an implant rep and started this phase of my life is I wanted to see what was going on in the different fishbowls. So I've been temping, filling in different offices. Okay, first of all, I went back to clinical practice after 30 years of working as a industry person. And it's so different now. And every office is different. But I found some offices were kind of behind the ball in implant care. And some offices really didn't have protocols. So, that it's for us as hygienists, it's important to understand what is appropriate protocols and how do we bring them into our practices so that everybody's on board. So my message is the hygienist and the doctors should be attending study group meetings together.
Oh, I love that. I wish we talked about this before the show, like going even with hygiene school and dental school, if they were, kind of integrated together, we would probably have a much more cohesive profession of dentistry, right? Not profession as hygienist versus dentist, but as a big collaborative event. I do want to just kind of lean into this education concept just a little bit more because I was watching something that you had done and you were talking a lot about, hygienists aren't really formally trained in implant maintenance, implant care, even just understanding, and hopefully we'll get into this a little bit later, but some of the pieces and parts and then, the nomenclature of implants, we don't really discover a lot of that until we take maybe some courses later on. But the dentists are kind of taught differently. And I was hoping you could speak a little bit to the different education that we each have.
Yeah, absolutely. This is important. So I live in Philadelphia, so I'm going to use the Philadelphia model for this interview here. University of Pennsylvania has a perio-prost residency. And this is very unique, where the residents are taught both to place the implants and restore the implants. So it's a prosthetically driven surgical program because you want to finish with the end result. You want to start with the end result in mind. You want to understand how the prosthetics should function. And then you're going to look at the patient periodontally, and do we have to grow bone? Do we have to do ridge augmentation to create the right environment to accept the implant to support the prosthetics? Without that education together, you may find a surgeon who didn't take a lot of classes on ridge augmentation, wanting to place a smaller size implant, and it has a big, huge prosthetic on a little skinny implant, and it creates a food trap. So the education can be different from one to the other. So you'll find someone may be quicker to place an implant where another person may want to be doing more grafting before placing the implant. So Penn has a very unique program. Temple University, I see when I was working as the oroscopic rep, which means when I knew nothing about implants and visiting their program, I knew that they were working with the niche textbook. I know that they're doing a good job in that education. I do believe that it is a perio. It is a perio program with prosthetic influence, but the Penn program, my understanding is, really focuses on these big reconstruction cases. Temple does too. So you'll find you have the oral surgeons who place implants. You have the periodontists who place implants. If I was going to have a single anterior implant, number 8, replaced, I want a periodontist to do it because I want all emphasis on making sure the tissue looks ideal. Again, because if somebody rushes into it and there's not enough bone, you may end up with black triangles, which aesthetically is not pretty. And it also creates food traps. Working with oral surgeons for Nobel, I found it was more of a mechanical discussion, and talking with periodontists, it was more of an aesthetic, gingival focus. So it's very interesting to see how differently the different specialties are taught to place implants. Dental students get the opportunity to restore implants while they're in dental school, which means somebody else is placing the implant surgically. And then the dental student gets to take the impression and order the laboratory cases to order the crowns to restore. And then they get to place the crown on top of the implant and use the little mini screwdriver and torque in the screw. So they get the experience of the restorative. So, that's the bubble I understand where I am with implant placement in my little immediate area. With Nobel, I live in Philly, but my territory is Jersey. So I would drive up to Newark and I would sit through the classes with the, it was called the Maxi class. And this was part of Rutgers Dental School. And this was a 16-week, 3 days a week intensive mini residency for general dentists to learn specialty on placing implants. And I found the graduates of that program that I worked with were very well-rounded. They planned cases well. I found them to be very conservative and understanding their digital workflow. So, that was the observations I had at this time. And then when I talked to hygiene programs, their program is taught on maintaining natural teeth. And I asked, well, how much time is in the curriculum towards implants? 1, maybe 2 classes senior year, last quarter senior year is geared towards the maintenance of titanium. My board patient, when I was in hygiene school, did have an implant, was a family member. So they may get some exposure to implants, but they may not get that same intensive amount of information that the residents receive now. We're segregated. We need to be doing this collectively.
So I think one of the interesting points here is, okay, we do have a lack of education as far as, and not even just education, but also experience. I think experience is a great educator. And so one of our main roles is to, I think, lead our patients into health. And I think placing implants is leading them into health, but sometimes we don't really know how to assess the same areas in the ways that doctors are assessing. Yeah. Do you mind just taking a couple minutes and just talking about like what is a doctor maybe assessing before they're placing an implant, and then how can we then do a similar assessment so that we can tee up that treatment for the patient to get healthier?
This is a good question. I want to give a little more definition to the question. Patients have different motivation to have tooth replacement. And so if we were having this conversation 20 years ago, be geared towards fixed prosthetics and cutting down natural teeth and creating a 3-unit bridge to replace a single tooth would have been treatment of choice. But what we now know is with bridge work, it's hard to clean underneath. Quite frankly, I think if I had a bridge and to use one of those little blue plastic threaders, might not be in my tolerance of every day. And we find that fixed prosthetics can fail due to caries between 7 and 12 years. So we know with fixed prosthetics, they probably will need the bridge replaced during a long lifetime. With implants, good news is implants do not decay. First of all, we won't have that issue with recurrent decay. You're going to not cut down the natural teeth on either side. And so what we're able to do is recreate that natural cleansable area that we would if we had 3 teeth in one place. So for replacement of single tooth, it's an interesting dialogue to have with a patient. One is, if a tooth is extracted, bone loss happens at its most rapid place with 6 months to a year after the tooth is extracted. So the purpose of the root is to maintain the bone volume of the alveolus. And if a tooth's extracted, we start to get this bone loss. So, finding that right candidate when a patient is addressing that there is a tooth that's failing or a tooth needs to come out, if you have somebody who doesn't have the means to replace the tooth and they're in pain, they just want that tooth out. They're not even going to have that conversation of bridge augmentation, or they call it socket preservation, where you put in some grafting material to maintain bone volume. But if you have a patient who's more motivated, has the means to follow through with tooth replacement with implants, that dialogue should happen. When do we want to move forward? When do you have time to, when do you have time? When can we do this for your patient? And, if you wait a long time after the extraction, the way they treat with implants may require grafting, where if we move forward, you may be able to extract and place an implant in the same visit. So that's single tooth. Then we have these patients with failing dentitions, where we're looking at extracting, say, all the teeth and then replacing 4 or more implants and then screw retaining a fixed prosthetic, the denture, onto the implants. And that, nobody says yes to that the first time they hear about it. They shop around for a long time. So that's a dialogue that you need to, are you happy wearing that denture? Do you get food cut underneath that denture? Would you rather see something that gives you better chewing function so you could eat more solid food? You have these, where's the patient's motivation? Is it me? I'm food motivated. If I was losing all my teeth and I want to eat steak, sign me up. Okay. Somebody else more aesthetic motivated. Some people that their dentures slip, so they don't, that's their motivation, is they want the dentures to be fixed in place. Find where they are and where's their motivating factors to move forward. There is a Facebook page of patients looking for having full arch screw retained prosthetics. And in that Facebook page, there's dialogue. Where did you get it done? How much did you pay? So there's this population looking for this procedure, and they're looking for the best price possible. And they're going out of the United States to have their work done. They're going to Mexico. They're going to the Dominican. And if I had a patient in my practice who traveled for that type of procedure, I feel like that's a failure, that I didn't hit the right motivating factor. Do you know what I mean? It's finding where patients are motivated and how to help them. So we're not selling, we're just providing solutions. We're educators.
No, I love that. I mean, and that's across the board, right? Anytime that we're not figuring out like what's driving our patients to either act or not be acting on things, is we are failing them if we can't figure that out. We're not partnering with them. We're not connecting with them. We're not loving them the way that we should as healthcare professionals.
Yeah, and we shouldn't assume they don't have the money. You need to really have that dialogue. Where is the motivation and what's holding you back? Because I'll find, it is, you don't know what kind of car they're driving. You don't know where they're vacationing. You've got to find out. Never assume they can't afford. Have that dialogue. There is financing. There is ways of paying these procedures off over time. Not just care credit, but there's other options too, and providing solutions for our patients. There's also, and I don't hear about it enough, but billing medical insurance. And I know people who help teach this. I don't understand why it's not embraced more. So this is, this could become one of my platforms I start talking about more, because it is available and it does work. I don't understand why we as dental don't embrace it.
No, I mean, you're absolutely right on that. We've done only one episode on it, and it's one of those things that I think that the offices that do embrace medical billing are super successful. And as a hygienist, it just allows you to provide that level of care to one more person, to 2 more people every month. It's not going to be a lot of people, but it's one of those things that you have, kind of in your armament that you can just use whenever you need, and it's a solution. I wanted to kind of pivot a little bit because I think motivating factors, things like that are really important. But I was hoping we could also talk a little bit about anatomical assessments. We have these areas of either single or multiple units that need to be replaced. I mean, my assumption is it's going to be a lot of like bone assessment, but also scanning and what are we looking at there?
So a three-dimensional scan, a CBCT scan, a cone beam, will give us a lot of information on bone volume. We as hygienists don't learn how to work with CBCT scans, but you're able to see how wide the amount of bone is versus how deep a bony defect is. And with a CBCT scan, you can also see where are the roots, compared to the sinuses. So when teeth are extracted and bone is resorbed, the bone surrounding the sinus becomes compromised. And a procedure called a sinus lift, which is, I feel like it's the wrong name for the procedure. And what they'll do is they'll access through the bone and push the membrane of the sinus and fill that space with grafting material to regrow the bone to accommodate for an implant placement. So when you're talking about anatomy, we have to be careful when we talk to our patients about what a sinus lift is so it doesn't scare them, because it is a very predictable procedure. It's a very easy procedure to do. It just sounds highly complicated and nobody wants to be messed around with their sinuses. So, the CBCT scan gives us a lot of information at that level on the maxillary arch. On the mandibular arch, when you have atrophic, lots of recession, lots of breakdown of the bone, resorption of the bone over time. They used to call them dental cripples where there's so much bone loss that you couldn't place the implants. And that's why when you're looking at these cases, a general dentist may be like, this is beyond what I should be doing, but I would like to refer you to a specialist. And that's the conversation I think needs to have more, is this is where my practice is comfortable. And this is the guy you want to tell, this is the doctor, this is the woman you want to see to have this type of implant case placed. Now, what's more interesting is that referral and the study groups with the referrals, and you'll have a surgeon that would like to show larger cases that they're doing. And so we as hygienists sit through these surgical cases, and it's not really what applies to us. We want to know, what do we do at the end of the case? But we as hygienists do need to understand what's involved in the surgical planning of these cases so that we can better communicate with our patients, because we have the quality time with our patients.
I love that you kind of teed it up, because that was going to be like the last question that we have is, things have changed a lot in the implant maintenance portion, like of what we actually do, the things we actually do care about. I had heard in one of your other podcasts, or one of the things that you've done. You've done so many things that, I loved how you came really hard against plastic instruments yet again, which is a conversation we've had for 10 years. It's not a new
Plastic instruments are cheap. That's why they're still in office.
But if you
put them in an envelope.
No, you're right.
Put them at the bottom of a drawer and see what time when you bring them back out. It's the original.
I would love to talk more about the instruments.
So the original implants were machined. They were not the rough surface that we have now. So around 2000, the surface texture and the surface chemistry of implants changed. So before 2000, there was a high rate of maxillary arch failures because the mandibular arch had a greater success rate because of more dense bone. Maxillary arch had higher failure rate because of the softer bone, and osseous integration required more time. So by changing the surface chemistry and making it more bio-friendly, we have faster integration on the maxillary arch. We have lower failures because of these surface chemistry changes. And part of that is they created this micro rough surface. So there was more surface area for the blend proteins to attach onto the implant. And if I compare another micro rough surface, think like an emery board. And if you took a plastic instrument across an emery board, you're going to see little shards of plastic left behind. You have to think of this at microscopic levels. And that when you're taking that plastic instrument against exposed threads of an anodized surface, you're leaving a non-biocompatible surface behind on the implant surface, which can attract bacteria, which can cause a secondary infection. So you really want to be using biocompatible materials. So on titanium implants, we want to work with titanium instruments, because if you work with stainless steel, the stainless steel can leave remnants behind also. Stainless steel is harder than titanium, so the stainless steel could cause some changes to the surface of the implant. So, and it's we're changing. We need to move on, but that message doesn't get out there enough. And think about it. The plastic instrument's being sold by the distributor, who doesn't know, but he's got this product and it's inexpensive. So that's how my brain sees all this.
Yeah.
That's how I see it.
No, I mean, you're right. You're right. I mean, that's the kind of the crux of all of this. And it's not even just the distributor, it's the cheap office, or it's the person that's in charge of ordering your office who has a certain amount of budget, but they only have a few more dollars left in the budget. But we're requesting an implant thing. Well, this titanium's not really in our budget, but guess what? Plastic sure is. And so we're going to go ahead and order it. Lynn, look, I wish we have so much more to talk about. We're going to do part 2, 3, 4, and 5. But the thing is, hygienists, you need to understand, we don't have the luxury of having the education that we need to have around implants. And we didn't even talk about prevalence, but you had mentioned it in one of your things about, the prevalence, like we're just getting more and more implants throughout all of our clinics, and we need to be better prepared for this. So Lynn, I know you also have classes. You have a variety of classes, different lengths. Can you talk about that a little bit before we end this?
Sure. I've just finished a bunch of local classes. I love to work with study groups, and I've just done probably 10 this spring. Small hands-on, where we have 2 to 3 hours of lecture, and then I invite the manufacturers to have the reps there, and we break into boot camp. And my class will break into small groups, and they visit each of the manufacturers' reps, and we do hands-on with each of the products. So that's a little study group format that I like to work with. I've done a few webinars, and this fall I'm starting to prepare for lectures that are more on the road. I'll be at the Southwest Dental Society in Dallas in August. I'll be at the ICOI with the American Dental Auxiliaries Association with the ICOI, and this is in Disney World. So this is the International Congress of Oral Implantology. I also have with the Western Society of Perio. So these will be larger classes, more in depth. And I'm available to book for study clubs. And in the fall, I will be speaking for Cloud Dentistry in September, and in January for Waterpik. So right now, I'm going from seeing like small local groups to a little more national. And I'm going to try and book a couple other webinars.
That's awesome. What is your website where they can find more information?
My business is Practice at Your Best. My website is www.practiceyourbest.com, and my email is lynn@practiceyourbest.com.
And listeners, I'll have all that in the show notes in case you want to just go ahead and click right through. That's probably the easiest way to do it. If you can't remember, although that's a very easy and nice URL to have. Lynn, thanks so much for being here.
Yeah. Andrew, thank you so much for having me.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.